So we'll start from chest X-ray, okay? This is not a very descriptive one. So yeah, I'll quickly go through, okay? Because we don't have much time with the August doctors. They just need a quick revision, right? So that's what I have not shared with other doctors because otherwise there are a lot of questions, right? So I really want to give the focus to the August doctors. Okay, so is August doctors are here or not? Okay, it's fine. We'll continue. So you all know, right, how normal chest X-ray is present, right? Normal chest X-ray, this is the way of it present, right? Okay, here in here you have see the heart, right? Heart, and here the aortic arc, right? Here the trachea you can see, and here the right lung field, and here the left lung field, right? And you can see in here the superior vena cava, and here the right bronchus, right? Here the trachea, then right bronchus, here the left bronchus. Right in this side, you can see the right atrium, right? And here the hilum, the right hilum and the left hilum, because these are very important, right? First of you all need to understand the anatomy of it, right? Then you can see the left hemidiaphragm and the right hemidiaphragm, and here the right costrophenic angle, right? Right costrophenic angle, and here the gastric bubble you can see. Right, other than that trachea, then here's the pulmonary artery, and here the left bronchus. The others are like a general idea that you understand about the general anatomy, right? Here, okay, what is number one? We'll quickly go through this. What is number one? What is number one, doctors? Quick revision, okay? Mm-hmm. Okay, good. Number one is trachea. So what is number two? What is number two? Number two is hilum, right? So yeah, hilum, right? Both side here, the left side and right hilum, right? So number three, what is number three? Number three, this area, the organ they are showing, it's lungs, right? Number three, both lungs are showing in number three. Then number four, diaphragm, right? Number four, left hemidiaphragm and the right hemidiaphragm, this side, right? So number five, heart, right? Okay, then number six, aortic knuckle. Here, aortic knuckle, or what we call aortic arc, right? Here, knuckle or arc. Here you can see, right? It's like a bump in here, right? Because very important these things. Okay, number seven, you can see the ribs, right? Number eight, where's number eight? You can see the scapula. And the number nine, it like breast here, you can see the, like breast tissues on it. Okay, like that. In here, you can see the bowel gas. Okay, here again, aortic knuckle, the bronchus things we just explained. Where's my pages? Okay, here. Left hilar, right hilar. This is trachea, right? Okay, these are not like, okay, no need. Okay, here, and we are categorized lung into upper lung song, middle lung song, and lower lung song, right? And here we all know, right? In each lung, they have the fissures, right? Left lung, what we have, upper lobe, right? Upper lobe, upper lobe and lower lobe divide by the oblique fissure, right? Oblique fissure. And the right side, what you have three lobes, right? Upper lobe, lower lobe, and middle lobe by dividing by oblique fissure and the horizontal fissure. These are the parts of the lungs, right? And here you can see the normal pleural and pleural space. Here you can see the normal pleural and pleural space by these arrows. Okay, then and these esophagus fissure and esophagus vein, not very important. Okay, so we'll discuss pathologies, right? Here is the liver and stomach bubble. The spleen is here, left hemidiaphragm, right hemidiaphragm. Yeah, like that. Okay. It's like a general idea. Claustrophonic recess, claustrophonic angle here, right? Here the angle, here the angle. Those are the general thing. Okay. Mm. And you know, right atrium, left ventricle here. Yeah. Yeah. Yeah, those are the main thing, doctors. Okay. So let's go through the these things. So, how you check the film first? You have to understand the rotation, the inspiration, and the projection and the exposure, right? So, rotation means medial end of the clavicle should be equidistant from the spinous process, right? Inspiration adequate if more than or equal 6 anterior or 10 posterior ribs visible above the diaphragm. The projection mean PA erect is standard at posterior anterior the standard anterior posterior portable supine may be magnify the heart like the projection right anterior posterior or like posterior anterior like depend on the different cases the exposure vertebral body is faintly visible to the heart like the things that you can exposure from the x-ray that you can see right and here also we have the ABCD approach airway but we can go with the airway. The trachea is central or deviated right. Here you have to check. So if it is towards the lesion, that there's a volume loss, right? If it is away from the lesion, there's a mass, rather the effusion, the tension pneumothorax, right? Because of the tension, the pressure, they are going away, right? Okay, then beam in the breathe in. Then you have to check the lungs, right? Breathe in the lungs. So look, you have to look for the any opacities like the luency, lung marking, right? Is there any mass effect, nodules, cavities? You have to check the breathe in the lungs. Then seam in the cardio mediastinum, heart size, borders, mediastinal width, and the hilers, right? The pulmonary vessels, those things you have to check. Then deep in the diaphragm and pleura, you have to check for the claustrogenic angle, right? The blunt angle, presence of meniscus sign present, right? The pleural effusion, yeah, and the diaphragm, those present, you have to check with it. Then the E mean the other than that, everything else, ribs, clavicle, the bone structure, right? You have to check. Right, this is understandable. And we have some key patterns like consolidations, like that mean the opacity, the white color opacity. I'll explain one by one. Okay, this is like a general idea. Opacities you can see in the consolidation in pneumonia cases. Atelectasis you can see the collapse at opacity with volume loss, right? So we can see the fissure, xylem, diaphragm pull toward the lesion, right? Here the atelectasis and the pneumothorax you have to understand, differentiate. I will explain. In the pneumothorax, you can see the white pleural lines, right? Pleural lines. And you can see the lung collapse here as well. Okay, the pleural effusion, you can see the blunt claustrogenic angle. So we call it meniscus sign, right? And there's opacity in the lower zone, right? Below the meniscal sign, you can see the white color opacity. Then pulmonary edema, you can see the bilateral perihilar, like bat twin. I'll explain, okay? Bat twin, what is bat twin? The hyperinflation, you can see in COPD, right? Mainly and asthma hyperlucent lungs, you can see the flat diaphragm increase the intercostal spaces because of the hyperinflation, right? Then you can see the cavity, especially in TBO lung abscess, right? Then, yeah, interstitial pattern, you can see the reticulonodular, especially in the fibrosis cases, right? I hope this is the general idea. If you want, you can take a screenshot or later I can share the screenshots of something. The same thing here I have explained. Okay, we'll go one by one. So in pneumothorax, what you can see in the chest X-ray pneumothorax, what you can see, doctors? Pneumothorax. What you can see. Pneumothorax, you can see the pleural white lines, right? Pleural white lines. So what are those pleural white lines? What you can see. Okay, here we have pneumothorax also. We have different types of pneumothorax, right? We have tension pneumothorax, primary spontaneous pneumothorax, secondary pneumothorax, right? A lot of types of pneumothorax we have, right? So first we discuss about the tension pneumothorax, the severe case, the emergency case, right? Here this is okay, what you can see here. Just 1 minute. Okay, sorry. Here what you can see. The signs of tension. The left lung is completely compressed. The arrowhead, right? The lung is the one here, right? Can you see? The lung is fully compressed here, right, doctors? Lung is fully compressed, right? Then the trachea is pushed the right. Trachea is pushed. Can you see the trachea is pushed away from the pneumothorax, right? Why? Because the tension is here high, right? The force is high here. Because of that, trachea is going away, right? The heart is shifted to the contralateral side. Note that the heart border is pushed to the right, red line, right here. Heart also pushed because of the pressure, right? Because the lung is collapsed here, right? The left hemidiaphragm is depressed in orange line here. Here also depressed, right? Important if you okay. Here, can you see? The lung borders are here, and here's the pneumothorax, the tension pneumothorax, right, doctors? I hope you everyone has an idea about it, right? Okay, this is the tension pneumothorax, right? So, what is the management of tension pneumothorax? What is the management of tension pneumothorax, doctors? Quickly tell me. Tell me. Okay, what is the immediate management? Immediate management. Immediate management. Okay, immediate management should be immediate decompression, right? Needle decompression. So, what is the definitive treatment? Don't confuse. Okay, immediate management and definitive treatment is two things, right? Right? So don't confuse. If they have given a scenario like X-ray and these things, then once they have what is the immediate management, what is the initial management, you have to think about what needle decompression, right? Because you need to, because this is emergency situation, right? Then if they have asked about the scenario, what is the definitive management? In that case, you can think about the chest tube drainage, right? So what are the symptoms that you can see in the tension pneumothorax? Tell me quickly. Quickly tell me, doctors. We don't have time. Okay. Tell me. Okay, chest pain, shortness of breath. Usually, okay, what are the key things? Like when after you can see this tension pneumothorax, you can see the sudden, right? Sudden severe shortness of breath, pleuritic chest pain, right? The patient is not in a like patient is having a like a severe chest pain, right? Patient is anxious, right? So other than that, you can say tachypnea, tachycardia, right? If some cases there can be hypertension, right? If the patient develop this and not treated, there can be hypertension as well. Right, doctors? Okay. Yeah, those are the things. Yeah, usually in trauma cases. So what are the other procedures? What are the post procedures that can cause the tension pneumothorax? Tell me, doctors, quickly. I need quick answers. Central venous catheter, right? Thoracentesis, like some cases like pleural aspiration cases, then pleural biopsy, right? Usually when they are doing the lung biopsies, right? So, I mean, after mechanical ventilations, right? There are questions in the emergency, post mechanical ventilation question. Those are the main things, right? Remember the sudden dyspnea, sudden chest pain, the heart pressure can be deteriorating, the hypertension can be present, right? Unilateral absent of breath sound here, right? Breath sound, you can think about this. Tension pneumothorax. Okay, so this is the typical presentation. So I'm not taking too much time for that. That's the picture. Okay. So here also you can see the pneumothorax, the large pneumothorax. You can see the white lines, right? White lines, and here the chest wall, then the white line. Because the lung is compressed, right? Here the width is more than 2 centimeter. In that case, we can call it as a large pneumothorax, right? Large pneumothorax. Here you can see here. So here CT also you can clearly see the tension pneumothorax, the tension or anything. Like you can see I'll show the better picture in e-medicine because every time they ask in this one. Okay, I will go with hemothorax. then you can show both of them. There are road traffic accident question, a lot of questions and CTs are given. Okay, where you can see the hemothorax and where you can see the pneumothorax. Quickly tell me. Okay, this is A. This is B. Where you can see hemothorax, where you can see the pneumothorax. Okay, hemothorax at the bottom right and the pneumothorax and here, like black color, right? I told you that they also black color. You can see the air, right? The fluid and everything in here, dense, you can see like this. It's a better question. Okay, so yeah, just for your knowledge, because these are very important. Okay, so yeah, quickly go through. I have attached extra thing, then yeah, you all know how to understand it. Okay, let's go with the hemothorax. Hemothorax, you all know, right? Blood entered the pleural cavity, right? Most commonly after the trauma, right? Especially the road vehicle trauma, we are getting a question a lot of, right? And hemopneumothorax is the most like commonest presentation, right? Commonest presentation after the trauma, okay? Not in all the cases. Here can you see blood in the pleural space and they are in the pleural space like the picture that we just show, right? Okay, so how it present, you can see the meniscal sign, right? Meniscal sign here. Here you can see the blood, right? Blood accumulation and the blood prostophonic angle, or we call it, or the meniscus sign, right? Fluid blunt in the prostophonic angle. So you can see like this. So what is the management? What is the management of hemothorax? Initial management, just hemothorax initial management, tell me. Initial management, doctors, please tell me. Okay, chest tube drain, right? So, okay, when you are going with the surgical interventions, when you are going with the surgical, there are four indications. Tell me all the four indications now. Four indications. All the four indications. Okay, what are the four indications? Quickly. Initial drainage more than 1.5 liter, more than 1.5, okay, not 500, more than 1.5 liters or 1,500 milliliters, right? The initial drainage or ongoing bleeding more than 200 milliliters per hour for 2 to 4 hours, right? That's the second indication. Yes, very good. Then, other than that, the third indication is persistent hemodynamical instability, right? Other things, they are suspected major vessel injury. So, if these things are present, you must go with what? You must go with the surgery. So, what is the surgery what you are using in here? It is thoracotomy or thoracostomy. What is it? Thoracotomy or thoracostomy, because you need to understand thoracotomy, right? Thoracotomy. Thoracotomy, right? So what is thoracostomy? Ostomy mean we are making a hole, right? Ostomy. So that means the chest drainage, the initial one, right? So initial chest tube insertion, we call it thoracostomy, right? Ostomy, we are making a hole, right? Okay, chest tube insertion, okay? Chest tube insertion. Not the nasal aspiration, chest tube insertion. Okay, initial one. Okay, then okay, simple algorithm is what first you have to stabilize the patient, right? Then you have to insert the chest tube. Then after inserting chest tube, you have to measure the blood volume, right? That draining from the chest tube. If there is an indication present, you have to go with the surgical interventions, or for indications, right? Yeah, I hope you get that. Here also you can see the hemothorax, right? Hemothorax. Okay. So that is done and dusted, right? Easy question. And I will show. Do you remember in here in the July exam we got the question with the rib fracture? Rib fracture very important. Okay, rib fracture. They have given a scenario. Hemopneumothorax both present, and there was a rib fractures as well. I think after initial stabilization or after initial interventions, Still patient is having the pain or something, right? I can't remember that. That is the image question. I'll show email. 1 minute, I'll show that question because please, the August doctors, you all are August doctors here. Go with that question. That is very important. Okay, this is the question. This is the question they have asked. Okay, the exact question. This is the exact question. Please take a screenshot. This question came on August exam. Okay, August exam. Very important. Give it a read. Okay. Here I'll show the I'll show. Okay, no, this one. Sorry. Okay, here. I'll show. Here rib fracture present here. Can you see the rib fractures here? Rib fractures show me like this. Here the hemothorax, right? Here rib fractures with hemothorax. And here rib fracture with hemothorax and pneumothorax here. Can you see? Rib fracture with hemothorax and pneumothorax. Yeah, this is how you need to understand, right? Very important. Okay, let's discuss about the TB. So TB, what do you know? Mainly you need to know the primary pulmonary TB, how it present, the miliary TB. Then other than that, okay, tuberculoma or like cavitation, TB, mainly in TB cavity here. Yeah, TB cavities. Okay, I'll explain one by one. So primary TB, how it present? Primary TB. There are no radiological features which are in themselves diagnostic of primary TB, but X-ray may provide clues to diagnosis, right? So, what is the criteria for diagnosing active TB? Active TB diagnostic criteria, doctors? Tell me, doctors, active TB diagnostic criteria. Okay. Once you're suspecting active TB, like symptoms. Okay, so what are the symptoms first? Cough, right? Persistent cough, fever, night sweat, weight loss, anorexia, hemoptysis, chest pain, those things can be present, right? So once you are suspecting active TB, what do you need to do initially? What do you need to do initially? Tell me, doctors. Chest X-ray plus what? Chest X-ray plus how many sputum sample? How many? How many sputum? Trace sputum sample, right? Very important. Trace sputum sample for AFB, right? Very important. These are like other things that I'm just asking, okay? So very important, very important. Okay. So yeah, here you can see the consolidation, right? Consolidation or highlight enlargement here you can see. Okay, then post TB lung cavity. How this lung cavity present? Here, same patient as image above. 4 months later, cavities are common finding in this TB infection, right? Cavities you can see like this, the pulmonary TB. Okay, cavities. Can you see the cavity here? Okay. Here, then other than post primary TB, what you can see, secondary reactivation TB is more common in immunocompromised individuals here. The upper lobe are more commonly affected. Apical consolidation. Often the consolidation often extend to the hilum. This is example, okay, only the hilum structure may be distorted due to the volume. Here you can see the apical consolidation. Here you can see in the post primary TB, okay. So just you need to understand how these consolidation present, right? The bite opacity, right? Okay, I'll show some pictures. Okay, how miliary TB present? Miliary TB. It's very important. Miliary TB, very important. So this is a very different presentation. How you can see here the miliary TB, like a presentation is like this, like miliary TB disseminated, right? Disseminated lesions you can see like this. Miliary TB. So here numerous tiny uniform well-defined nodules, right? Like a dot, like a millet seed, right? Millet seed, not very clear, but you can see like this kind of image in miliary TB. Millet seed appearance may be normally early or in immunosuppressed, right? So this is the way you can see. Then other than that, because these are the like complications, fibrotic changes later, lymphadenopathy, the higher lymphadenopathy you can see. Right, and because of this, there can be lung abscess, TB cavities, right? Cavitational lung cancer later can be seen. And tuberculoma, well-defined nodule, you can see. I will show better picture. Tuberculoma. Yeah. Can you see? What is tuberculoma? What is tuberculoma, doctors? It's like a mass, right? It's a granulomatous mass that caused by this bacteria, right? TB bacteria, right, doctors? TB bacteria. Mostly common you can see in where? In the brain also you can see, right? The tuberculoma mainly. Okay. And here lung as well. Because the TB, yes, TB is not only limited to the lungs, right? Yes. Not only limited to the lungs, we have extra pulmonary presentation as well. Okay, yeah, those are the things. Other than anyway, if they have given the TB presentation and the pleural effusion, you know how many skull sign present, and the cavitations are usually in the upper lobe, right? I think they have given in TB the cavitations in e-medicine like 2 or 3 questions. Here you can see in the primary TB, hilar lymphadenopathy, the consolidation reactivation of TB upper lobe. So upper lobes cavities you can see, miliary TB, countless tiny bilateral nodules, right? Heel TB, there can be fibrosis, volume loss, calcification, those things you can see, okay? Okay, so pneumonia. What do you know about pneumonia? Pneumonia, we have lobar pneumonia, bronchopneumonia, interstitial pneumonia, or atypical pneumonia, right? We have aspiration pneumonia, right? So those are the main things, main types of pneumonia, mainly the lobar pneumonia. How the lobar pneumonia present? Lobar pneumonia, one lobe become relatively uniformly white, the white opacity, right? Okay, I'll show the example. Here the right lobe, they are not showing it as this color, okay? Because they have colored this to specify it. Consolidation you can see right here, the right upper lobe. Okay, then here you can see the right middle lobe consolidation. Then here also consolidation you can see. And here consolidation, here complicated with the effusion. Can you see the consolidation and the effusion, the meniscal sign as well, right? Like that. Okay, so in the lobar pneumonia, you can see it as a consolidation. The lobe is consolidated. So bronchopneumonia, how it present? So bronchopneumonia characteristic by multiple small nodules or reticular opacities which tend to be patchy or confluent. This represent the areas of lung where there are patches or inflammation separated by the normal lung parenchyma, right? So what you can see in here, you can see multiple nodular or reticular opacities, right? Here also opacity, but not the lobe. That's not fully lobe is associated, right? There are not tiny. There are patchy. Not actually. Yeah, can be patchy. Okay, I'll show a picture here. In the patchy airspace opacity throughout the right lung. In the right lung, you can see like patchy things, right? You can see. Yeah, like here, different kind. Patchy. Can you see? Like that. Okay, like that. Okay. So there you can see because they are not lobal involvement like that. No bronchopneumonia. And how you can see the atypical, especially what is they are asking about the example, the mycoplasma pneumonia. You can see the bilateral patchy infiltration, right? Bilateral patchy infiltration. Can you see here? Very important, right? Very important. Very important, doctor, this one, okay? Because they have asked in July exam as well. I'm so sure they will ask on this August exam as well. Because like previous month recalls are repeated a lot. Okay? Here you can see the thickening peri-peri highlights into the lung base with inflammatory lower airway. There are non-segmental patchy lung opacities here. You can see the patchy lung opacities in these areas. Remember, bilateral patchy lung infiltrated, usually think about the mycoplasma, right? Okay, how these fibrosis present? Fibrosis present, doctors, fibrosis. Fibrosis present like the reticular shadowing, not the different infiltrate. There's a shadow, reticular shadow of the lung peripheries, which is typically more prominent towards the lung bases. It may cause the contour of the heart to be less distinct or shaggy, right? It's like a net-like shape, the fibrosis. Can you see the fibrosis in here? Net-like shape. And the shaggy heart border here, can you see? Okay. Okay, I'll show a better picture. This one is colored because we can better see from the in the CT, not in chest X-ray. Here, the picture that I got. Can you see like a net-like here? It's a net-like the reticular net-like shades right here. Can see everything you can see here. Here. Okay, like that. Okay, then, okay, what you can see in the CT, very important, doctors, okay? Because we have what? We have what? Honeycomb bin and what is the other? Ground glass opacity. So, what is the difference between this ground glass opacity and honeycomb bin? Very important in CTs. So, the honeycomb mean what? Honeycomb means cystic appearance. Cystic appearance. The ground glass opacity mean the hazy opacities, right? Here the ground glass, you can see the vessels are visible, but in honeycomb the vessels are not visible. I'll show the example, okay? Usually you can see the ground glass opacity in early inflammatory cases, and if it is like a late scenario, you can see the fibrotic changes. In that case, we can see the fibrotic changes. Sorry, we can see the honeycomb bit, right? Very important. Here, ground glass opacity, because it's initial, often reversible. But if it is a honeycomb in the late stage, the fibrosis is irreversible, right? Here, the examples pneumonia, ARDS, you can see the ground glass opacity. Early cases with honeycomb in IPF, those cases you can see. Okay, just think ground glass infection or inflammation, the honeycomb in the end stage, the fibrosis. I hope you get the idea. Here, what you can see, the honeycomb cyst here, honeycomb in you can see. Sorry, honeycomb between the fibrosis, right? Fibrosis, the late stage. And here what you can see, here the ground glass appearance. You can still see the vessels right here. Okay, I hope here is like a honeycomb, right? It's like a even like very fibrosis, but here it's kind of smoother than this one, right? To think like that way, then it will be easier for you. Here, patient after COVID-19 disease, COVID-19 due to the inflammation, right? Initial. That is extra thing for you to understand. Next, discuss about the sarcoidosis because they are giving the sarcoidosis as well. Sarcoidosis, right? So what you can see the sarcoidosis. Here, chest radiograph have been the mainstay of staging of thoracic sarcoidosis in many decades for fair inter-observed concordance. However, the systemic correlate the poor with symptom severity except pulmonary disease, pulmonary function test need for the treatment. HRCT and this FDG PET can be, PET scan can be provide more information than chest x-ray. But here still we are getting the chest x-ray because there we have some very important things. So what we can see in here, hilar lymphadenopathy, right? So very important. And here the chest x-ray classification, chest x-ray has like different stages, right? Because in the stage 0 to we have stage 4. According to that, we have decided the, here you can see. Here you can see the 0, 1, 2, 3, 4 sarcoidosis. So let's see what you can see. Here is very better. Now here stage 0, you can see the normal chest radiograph, right? In stage 1, you can see hilar or mediastinal nodal enlargement. Here can you see the hilar enlargement here, the both side. Stage 2, nodal enlargement and parenchymal disease here. Nodal enlargement as well, parenchymal disease, parenchyma also associated. In the stage 3, parenchymal disease only. Here you can't see hilar lymphadenopathy, but parenchyma can be seen here. Stage 4 and stage 1 pulmonary fibrosis because they are becoming fibrotic, right? Here can you see they're starting the mesh-like things, net-like thing, right? The reticular. Then here it's like you can see the periphery, the fibrosis. Here fully fibrosis, the end stage, right? I hope you get the idea about it. Hi, doctors, end stage, fully pulmonary fibrosis. Okay, let's see what I have attached. Okay, let's discuss about the COPD. How hyperinflation present? Hyperexpansion or hyperinflation? Okay, here in normal subject, the diaphragm is intersected by the 5th or 7th anterior ribs in the mid-clavicular line 6 or 7. Here, if it is in often difficult to see in the ribs in patient with COPD as they are osteopenic due to the long-term steroid use, as in this patient. You can see, right? Often difficult to see the ribs pattern, right? Here, you can't see the ribs pattern due to what? Osteopenia, right? In this image, the 7th rib, which are only just visible. Okay, 7 ribs only just visible. Okay, which are only just here intersect the diaphragm, the red line. Here intersect the diaphragm level with the mid-clavicular line. Here the mid-clavicular line. So the lung are hyperexpanded. Here, patient positioning and use of accessory muscle respiration can influence the anatomical positions of the ribs and chest X-ray. Flattening of the diaphragm. Here you can see not like a curvy appearance, right? The diaphragms are flattening, right? Diaphragm is flattening. Why? Because using the accessory muscles and all, right? Because of the hyperexpansion. The green dotted lines indicate the predicted normal diaphragm shape and position, right? Here, this is a normal shape, but here you can see it's going down as well as the diaphragm is flattened, right? Hi, doctors. I hope you get the idea. Because it should be normally a diaphragm intersects by the 5th or 7th anterior rib in the mid-clavicular line. Be here, but here in this area, it's like going down, right? Hyperexpansion. And COPD, other than that, what you can see, float in heart sign. So what is this float in heart sign? The lungs may be hyperexpanded and the inferior border of the heart become visible. The heart appears to be float above the diaphragm. Can you see? It's above the diaphragm, right? Above the diaphragm. So yeah, here the not flat hemidiaphragm here. So you can think it as is a floating, not connected to the diaphragm. Why? That's why we are calling it floating heart side, right? Is everything understandable? Till now, everything is understandable, right, doctors? If you have any question, just ask. Okay, I'm quickly explaining because I want to save time for the August doctors, right? Okay, if you have anything, just ask me. Okay. Okay, here, so here, infective exacerbation of COPD. Here you can see the bulla appearance, but not very clearly. Okay, that's no need. So we'll go to the lung cavity part. Okay, lung cavity or lung abscess. So here, the classic appearance of pulmonary abscess is a cavity containing the gas fluid level, right? Can you see here's the cavity and you can see the air and fluid level, right? Here in the black color, the air, and here the fluid level, right? So abscesses are round in shape and appear similar both frontal and lateral projections. Additionally, all margins are equally well seen, although adjacent consultation may make the assessment of this difficult because most of the cases there can be a pneumonia and as a complication there can be abscess, right? Okay, so these in that case you can see the consolidation as well as the abscess, right? These features are helpful to distinguish pulmonary abscess from the empyema. Here, the lung abscess. Here, the fluid level and the cavity is here, right? Okay, here. Here, the lung cavity abscess. The lung cavities can be caused by disease process other than infection. This patient has a lung cavity which was initially thought to be a cancer but which disappeared after course of antibiotics, right? The cavity was therefore correctly termed as a lung abscess. Okay, so how asbestos is present? Asbestosis. So how asbestos is present? I think this question came, asbestosis came in. Okay, you can see asbestosis as a plaques. Okay, what about the doctors? Okay, I think in July we got some questions, right? Asbestosis exposure, right? Something can't remember properly. Okay, we'll do. Here, asbestosis plaque, right? What? How you can see? I said mesothelioma. Okay, okay, mesothelioma question. Yeah, I think. Can't remember doctors because a lot of questions I'm doing the records. In my brain is like, oh, I remember something June came, but I can't sometimes take it out from my brain, right? Because it's sometimes like a mixed jam. Okay, here. Calcified plaques are associated with the previous exposure to asbestosis and are almost invariably asymptomatic. Can you see the plaques? They have colored here. Plaques here, plural plaque. They appeared as an irregularly shaped area of the calcific density as white as bone, right? White plaques and shows not to be mistaken for area of consolidation. The pleural plaques are benign entity, do not lead to cancer or mesothelioma, and their presence does not equate to the diagnosis of asbestosis. Not asbestosis is a fibrosis of the lung caused by the presence of asbestos fibers in the lung themselves. It may have similar appearance to the fibrosis seen in the previous page from the like a previous the fibrous one. Okay, fibrosis we just discussed. So here the example here, so like you can see the large plaques, right? Here pleural plaque may have well defined edges here. Some plaques may be very large here, very large. And the plaque form the parietal pleura, including that the mediastinum, mention arrowhead and diaphragm. So you all know where's the mediastinum and the diaphragm. So here, okay. So here, let's discuss about the pleural effusion. Is everything clear about asbestosis, right? Asbestosis, the plaques and everything. Okay, the pleural effusion. What you can see. What you can see here, can you see the large pleural effusion? Pleural effusion caused by heart failure may not be symmetrical. This patient with the heart failure and has been nursed on the right side before his X-ray was taken. Fluid has accumulated in the right pleural space. The right claustrophonic angle is not visible here. It's very hard to even visible the claustrophonic angle. That much fluid is here, right? So no effusion is present in the left pleural space. So no effusion. And the left heart borders is not distinguished because of the pulmonary edema of the adjacent lung. Here, the pulmonary edema. I will explain how pulmonary edema present. Okay, there are a lot of things that you need to understand about the pulmonary edema. Okay. Yeah, large pleural effusion. Here, pleural effusion is meniscus sign. Mediastinum will shift because of the pressure. Mediastinum go away. Like think like that. Otherwise, it will be. There can be confusion in those pneumothorax. So hemothorax. So this pleural effusion. Where to go? This which side is the trachea deviation because of the pressure. That should be the push, so because of that, going outward, right? Think like that way. So other than that, the next thing is pericardial effusion. How it present? So effusion means something like fluid accumulation, right? Remember the pericardial effusion, you can remember as a water bottle sign, right? Water bottle sign. Can you see it's like a water bottle, like a pretty water bottle, right? It's like ancient water bottle. Just 1 minute. Okay, doctor, just 1 minute. I need to put the charger in. Okay, here you can see the water bottle sign right here. It's a large water bottle. Remember this water bottle, okay? Not like the typical water bottle. It's like here, like that. It's like a nice pot, right? Okay, here the water bottle sign. Here enlarged globular heart. It's like a water bottle, right? Pericardial effusion. Okay. How this atelectasis is present? Atelectasis is very important. How this atelectasis is present? Atelectasis is present. How? What is atelectasis, doctors? What is atelectasis? What is atelectasis? What do you know about atelectasis? It's a lung collapse, right? Collapse of the lung, right? Okay, collapse of the lung. So, what are the like? Okay, in which cases we can say the atelectasis? Which cases we can see the atelectasis? That is also very important. Very important where we can see the atelectasis. Mainly the post-operative, right? Post-operative, very important, right? Post-operative. Yes, post-operative. Other than that, if there can be other like less common due to foreign body, right? External compression, those things, but mainly post-operative, right? So, what are the symptoms that you can see in atelectasis? Symptoms: dyspnea, tachypnea, right? Hypoxemia, cough, right? Okay, if it is a very little one, there can be asymptomatic acid, right? So, what are the typical chest X-ray? Typical X-ray features, right? So the thing is here, what we are losing, the volume, lung volume is the one we are losing, right? The lung volume, very important, right? Lung volume here. Okay, here, but you can see the pulmonary opacities, you can see. Then AR bronchogram, tubular outline of the smaller airway and Silhouette sign, right? Obliteration of normally clear outline between the lung, feet, and adjacent structures. Right, so what are the features of evidence loss? Crawling of pulmonary vessels, undeflation, hemidiaphragmatic elevation, tachia deviation towards the area of atelectasis. So what? Volume is losing, right? The volume loss happened because of that trachea is coming towards it, right? Right, doctors, that is the important thing you need to differentiate with the pneumothorax or hemothorax, right? The trachea is coming towards here in like pneumothorax or hemothorax. The trachea is going away, the opposite side of the collapse, right? But here it's coming towards the because why? Because due to the volume loss, right? Volume loss here increase the white opacity in the affected area, reduce the lung volume, displacement of fissures towards the collapse area. Hilum may be pulled towards the collapse, mediastinum trachea may be shifted towards the affected side. Elevated hemidiaphragm on the affected side and crowding of the ribs may be occurs. Compensatory hyperinflation if remains. Okay, here. And you see the trachea also, it's not very clear it here. Okay, clear it here. But you can see the white opacity here, right? White opacity here. And the heart displaced into the left hemithorax. Okay, heart is displaced in the left hemithorax and the diaphragm is obscured. Okay. Then there are air bronchospasm present suggests with the consolidation as with this side. Okay, here doctor, I will try to find the better. This one is not better. I need to like show it very clearly with the letters. Mm, some pictures is very hard to find. Loading even. I want to show this format letters. Here also you can see, but not the very typical presentation. I had one picture here. Here you can see. Can you see the trachea? Trachea towards this side, right? Can you see? Trachea is going the affected side. Here's atelectasis. So here's due to the tumor. Yeah, okay, this is a better picture. I should take a screenshot. Because otherwise you won't remember if you can't see the trachea deviation. It's the most important thing to differentiate from others, right? Here atelectasis is present. Mm. Here also this side collapsing present. Here, okay, here also trachea going towards it. Oh, this is pneumothorax. I don't know. I think pneumothorax and here, okay, pneumothorax also here you can see. It's like a complicated picture. Both are present. Okay, here I think this is the better one. Okay, this is the better one. Okay, because these are like very important, these two to differentiate. Okay, main problem here, lung volume loss. Here the air in the pleural space, right? Here the chest appearance, increase opacity here in white, and here increase the lucency, the black color, black and white, very important. Okay, black and white, because due to the air, you all know air can see in the black color here, because here the due to the lung volume loss, right? Volume loss means the air is losing, right? The volume is lost. So in that case, you can see the white here, the lung marking present with the remaining lung. Here the volume is reduced. Here the mediastinum usually pull towards the collapse side here. Tension because of the pressure that push away the away from the pneumothorax, right? This is the most important thing to understand. Okay, here opacity volume loss. Here you can see the pleural line, no peripheral lung marking, right? Okay, so other one is the pulmonary edema. This is very important. Okay, pulmonary edema. So where what you can see, pulmonary edema, accumulation of extravascular fluid in the lung, right? That occur due to the various mechanism, but most common is cardiogenic pulmonary edema, often stemming from the left heart failure. And other than that, there can be these causes as well: embolism, neurogenic pulmonary edema, perfusion, transition related pulmonary edema, right? Okay, how you can see? How you can see, doctor? So the antler sign, there is an antler sign. So blood is redistributed to the upper lobe veins, causing them to dilate, right? I'll show a better picture, not like this. So we call it, it's like an antler, right? Like here the vessels are dilated, so you can see like this. Okay, so other things what you can see, interstitial edema, thickening of bronchial walls, also known as peribronchial cuffling, loss of airway definition create the hazy appearance. Can you see the hazy appearance? Then curly B lines horizontal line at the lung base indicate the thickening. Interstitial thickening. That is not very important, okay? But just give it a just keep some idea because of this hazy appearance, right? The fluffy opacity, the bat fin. This is the bat fin sign. Bat fin sign. So when the fluid accumulates rapidly, you may get the classic bat vein sign, like the proper pulmonary edema present. You can see the black. Can you see it's like very dilated? Can you see it's like a bat-like things? Here the mitral, also not in the case of mitral regurgitation, the jet is direct towards the right side of superior pulmonary vein, and several mitral regurgitation can present with the right upper zone consolidation. But here, due to the pulmonary edema, you can see the white appearance like a bat wing, right? Bat wing, like that. And here, these are the features that you need to remember about the pulmonary edema. A, B, C, D, E, A mean alveolar edema, bilateral consolidation, curly B line, interstitial thickening. C, cardiomegaly, more common in cardiogenic causes. So D, vascular redistribution, dilated upper lobes vein, right? Dilated upper lobes. So here, antler sign. Okay, dilated upper lobes vessels. Then what is other things? The E-mean effusion, bilateral blunting of angles because of the fluid accumulation. Remember, these are the things that you can see in the pulmonary edema, right? Pulmonary edema. Okay, here you can see all of those signs, right? Here you can see a pulmonary edema case. Okay, I hope you get the idea of pulmonary edema. So how the lung cancer present? So you can see it's like a mass, right? Here, here you can see a mass appearance, right? Mass appearance. And here cavitational lung mass also here. So how cavitation lung mass? Can you see the mass here and the cavities? It's a cavitational lung mass. Then what else? This is the CT. Okay, so this is the cancer picture. There can be anywhere, right? But you can see this kind of appearance, right? Okay, and here. Okay, how Pankos tumor present? Pankos tumors typically present with what? Shoulder pain, neurological symptoms, right? Due to the brachial plexus involvement, sympathetic chain of vertebral bodies. The combination of significant smoking history, chronic cough, and upper limb neurological symptoms should prompt the chest imaging before pursuing investigation. So anyway, remember, if they are first line, okay, if they have given a scenario of Pankos tumor, and if they ask what is the initial investigation, always go with chest X-ray, not the shoulder X-ray. Okay, because sometimes doctors are doing the mistake. Once you see the X-ray, you are not doing other part, and you just mark it as the X-ray. Sometimes you can mistakenly mark it as the shoulder X-ray, right? They are giving like that. So yeah. And so tell me the like proper symptoms: shoulder pain, hand muscle atrophy, right? Shoulder pain, hand muscle atrophy, dishonor syndrome, right? Those are the things. And these numbness, paresthesia due to these brachial plexus involvement, right? Okay, here can you see the apical tumor like that? Okay, so next one, the cardiomegaly. Cardiomegaly, doctors, cardiomegaly, you clearly can see the cardiac width is high, right? Cardiac width is high, history of hypertension and angina. The presentation has enlarged heart. Here, you have the cardiac width here, a large cardiac width, right? And thoracic width also here. And here, it's a mild case. Can you see the mild case? The thoracic width and cardiac width compare with it. The cardiac width is reduced, right? But here it's like almost more than 68, right? Here, can you see the C mean the cardiac width, T mean the thoracic width, R mean the ratio. Okay, CTR more than 68. Here, more than 50% from the thoracic width, it has increased. But in here, it's like 53, around 50%, like half of this thoracic width, right? Like that. Okay, so aortic dissection, how it present aortic dissection, doctors? Aortic dissection, chest X-ray finding. I have explained the CT, right? Chest X-ray, how it present. Mm-hmm. You can mainly see the mediastinum, wide mediastinum, right? Can you see the wide mediastinum here? Wide mediastinum, right? Okay, you can clearly see the wide mediastinum here. The X-ray demonstrates the wide mediastinum in combination with the chest pain and indicate the likely diagnostic of aortic dissection. So, what is the clinical presentation of aortic dissection? What is the clinical presentation of aortic dissection? Tell me, doctors. Very important. Mm-hmm. Sudden onset, severe chest pain, right? That radiate into back. If you heard these things, think about aortic dissection. Very important. These are like keywords. But sudden onset, severe chest pain that radiate to back, right? Very important. Very important. These things, right? Very important. Okay, and in the other than that, cardiomegaly can be seen, right? Yeah. What else? Yeah, those things you can see mainly. Okay. Okay, it's unfold in aortic knuckle because you can't see it in here, right? Okay. Now I have attached a few of other main things that they can ask about pediatric group, right? How the group present in chest X-ray. You can see the steeple sign, right? Steeple sign. Can you see here? It's a subglottic narrowing, right? Steeple sign here. A staple sign, right? Can you see it? Staple sign. Epiglottitis, what you can see the thumb, right? Thumb sign, right? Doctors, the thumb sign. Can you see it's like a thumb, right? But you can see the swollen epiglottitis. Swollen epiglottitis, you can see it as a thumb sign, right? Here, the epiglottitis, then this is the no. You can see that it's inflamed. So, thumb sign. Then dextrocardia. Dextrocardia mean what? Cardiac apex points to the right, right? The majority of cardiac node lies in the right hemisphere. Here, it's supposed to be in this side, but here it's in this side, right? The right side. So it's a dextrocardia. So right-sided heart, right? Dextrocardia. Dextro mean the right. Then, other than that, what you can see in the one of main important the tetralogy of Fallot, what you can see, TOF, TOF, what you can see, doctors, boot shaped heart, right? Boot shaped heart. Can you see the boot shaped heart? Very important. Boot shaped heart. Okay. It's a very typical presentation, right? Boot shaped heart, and here you can see boot shaped heart. Other than that, right ventricular hypertrophy, right ventricular hypertrophy, right sided aortic arc, and the pulmonary bay flat due to the infundibular pulmonary stenosis, pulmonary oligema. But remember the boot shape part, right? So transposition of the great arteries, how it present. Have you seen the eggs on a string? Eggs on a string appearance. This is the egg on a string appearance of potato. Okay, eggs on a string or potato on a string appearance. This is the appearance you can see. Right, you can see here. Yes, that's all for like the general idea about the not everything has covered, but main topics have covered in this chest X-ray. Usually, the mainly asking topics, not the rare topics. Okay, is everything clear, doctors? Is everything understandable? Okay, so yeah, okay, we'll take a small break. We will take a 10 minutes break and we'll continue next part, CT and here the derma part. Derma part, actually, this file I have done already. We want to do it again, or Like you can watch the video because today only I realized I have done this one in March exam in before March and I have already uploaded that in YouTube as well. What do you prefer? Do you really want to go through this one today as well, or what do you prefer? It's up to you. X-ray abdomen I already discussed, doctor. X-ray abdomen I already discussed. Okay, so okay, quickly I'll show the pictures. Okay, I'll show the pictures. And other than that, you can because in that case, I think I have explained a little bit advanced than this. Okay, so we'll take a 10 minutes break. 36, okay, 37, 47, we'll come back. Okay, we'll discuss. Okay, we'll quickly go through the. Okay, first we'll discuss the CT. Then we will go through this one. Okay, CT also I'm not deeply explaining. Okay, because like you don't have time to go through very deeply, but I will show like the mainly as things only. Okay, CT head. Okay, so here what you can see the basics. Okay, here. So just orientation. So we have axial CT. This is the most commonest one they are giving, right? Most commonest one. So left side of image, right? So that means the patient's right? The right side, the patient's left. Top of image is anterior and the bottom is posterior, like this. Okay. And very white, very bright white, you can see the bone, right? Then you can see the white in acute blood. Remember, very important, acute blood you can see in the white color, the gray brain parenchyma, right? Here the brain parenchyma, the dark color. The dark color, what you can see, cerebral spinal fluid, edema, and the infarction. Those things you can see in the dark color, right? So black color, there can be air, right? Remember the blood, the bright white. Right, so very important. Here we are approaching it like a BBVMB. So you have to first check for the blood, any hyperdense blood, right? You can see how blood, the bright white, right? Blood is present on. Here, can you see the acute blood here? Here, right? Then you have to check the brain parenchyma, any abnormal in the brain parenchyma. B, blood, then brain. Other B is the basal cisterns, right? Open effect or any blood present. And then we mean the ventricles, the size, shape, symmetry, any blood. Because the ventricles, like you can see the dilated ventricles in where the hydrocephalus, right? Like that. Then you have to check about the M midline. That means is there any midline shift present or not, or mass effect present? I will explain what is mass effect. Then you have to finally check the B. Other B is a bone, right? Any skull fractures present or not, right? So we going through BBVMB. Okay, you don't know, need to remember everything, but just is the way that you should try to understand. So yeah, and here also we have axial, coronal, and sagittal section. Okay, sagittal section of the chest X-ray, but mainly they are giving the axial cases, right? Axial cases, and here hyperdense mean the darker than normal. Hyperdense. What is this? I don't know. I can't remember. No, I cannot remember it. I can't read what they have mentioned here. But anyway, the hyperdense mean what, right? Hyperdense. So yeah, no need to read this one. Okay, that is not very important. I got this image from the Google. Okay, we'll quickly jump into the things. Okay, here hyperdense white. White mean you can see mainly blood. Okay, acute blood. The bones calcification, those things. The hyperdense, the darker one. CSF, cerebral edema, very black. Yeah, right. Okay, and here's the the normal anatomy. Right here, the frontal lobe you can see. Frontal lobe, then basal nuclei and the related structures from here. Diencephalus here, then here the temporal lobe, lateral ventricle, the parietal lobe, the occipital lobe, lobes are in here. Then the third ventricle, the frontal horn of the lateral ventricle. So you all know like how the ventricle appearance here, like in here. Okay, like that. Here, then other than that, we have gyrus, right? We have gyrus and sulcus, right? Here you can see the gyrus in here. I'm not going to read everything because this is a general anatomy, right? Anatomy. And other than that, you need to understand the where is this lobe location, occipital, the parietal, right? Those things. And here, the thalamus in here, then sulcus, those things. Yeah, no need to like in detail go at the moment because we have the limited time. So yeah, we'll jump into the hemorrhages part, right? Mainly they're asking from this part, very important, okay, very important, how these things present. So we have the brain hemorrhages, extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, intracerebral hemorrhage, very important, okay? So how you can see this extradural hematoma, doctors, how it present? Extradural hematoma. So extradural, that means between the skull and dura, you can see, right? Skull and dura. The source is the middle meningeal artery, right? You can see the biconvex or lens shape. Okay, I'll show a picture. Okay, here, can you see the lens shape? Can you see the lens shape, doctors? Here, we call it extradural or epidural, right? Extradural or epidural. So how you can remember it as? I usually remember it as, it's like a, remember, epi pie. It's like a pie, right? It's like a lemon. Lemon, right? Remember the epi lemon pie. Epi pie. Okay, remember, right? Then subdural, you can remember it like a this crescent shape. Oh, how? Remember banana and lemon. This is the easiest way you can remember these two. Subdural banana, epidural epipie. Pie, like you can make a lemon pie, right? So remember the lemon and the pie. Okay. Here also, here you can see. Then you have what? You have the subdural hematoma. Subdural means between dura and the arachnoid, right? Dura and the arachnoid. So here the bridging veins are associated. You can see the crescent shape. I just show you crescent shape. The crescent shape, or like remember it as a banana, right? Banana. Then acute seated, here you can see, anyways, the hyperdense you can see, right? Yeah. Okay, and what is the typical presentation in subdural? Is subdural, what is the typical presentation, doctors? Subdural hematoma. Tell me. What are the very important things you need to understand? Usually in, yes, usually in elderly patient, right? Elderly patients, right? After these falls, right? And alcoholic patients, right? Patients who are using these anticoagulation drugs, right? Those patients, right? And we have what? We have what? Two types of subdural hematoma, right? What are these two types? We have what? Acute subdural hematoma and what is the other one? The chronic one, right? So acute one usually due to the head trauma, right? Patient can have the headache, right? The confusion, vomiting, acute deterioration, right? Then focal neurological deficit you can see. If it is a chronic case, how you can see? It's like often after a minor trauma or minor fall. Like then later, like weeks later you can see the like gradual worsening of this headache, right? Confusion, the drowsiness, the cognitive functions failure, those things you can see in here, right? But it's a chronic, right? Not the acute like in this thing. Okay, so you can see the crescent shape, right? Crescent shape in here. Then what about subarachnoid hemorrhage? What do you know about subarachnoid subarachnoid hemorrhage? Subarachnoid. Very important. What is subarachnoid? It is a thunderclap headache, right? Thunderclap headache, worst headache, right? Worst headache of life, right? Worst headache. It's having like a maximum severity, maximum pain, right? Worst headache, right? Worst headache of the life, right? And that can be associated with the nausea, vomiting, right? So what is the associate? The artery, the rupture of intracranial aneurysm mainly, right? Aneurysm is mainly associated, right? It can be seen in subarachnoid space, right? Blood in sulci, then fissures and the basal cisterns you can see, right here. So subarachnoid, here hyperdense blood in sulci, fissures and the basal cistern here you can see. Like in this is the CT appearance. This kind of CT you can see. I'll show a better one. A minute. Not very clear here. It's not very clear. Mainly due to the berry aneurysm, right? Berry aneurysm you can see. Can see like in here. But that picture is better. 1 minute I'll show a better picture. I didn't have actually time to make a better one. I just today I just within like 1 hour I made this file to teach you properly. Here you can see the subarachnoid hemorrhage. Here, white color, bright red. Okay, like that. Okay, then what else? Okay, the other one is what? Intracerebral hemorrhage within the brain parenchyma, right? Small penetrating vessels often related to the hypertension, right? Irregular focal blood within the brain tissue. Here, can you see the intracerebral hemorrhage in the parenchymal tissue? Here, like that. Okay, I hope you get the idea. Right? Okay, here just remember lens or biconvex or the banana shape, epidural, right? Crescent shape, sorry. Sorry, doctors, just give me 1 minute. Okay, sorry. So here, lens biconcave, you can see in epidural or extradural, right? Epidural, extradural, the banana shape, the crescent shape you can see. Sorry, the lens biconvex and the lemon, okay, lemon in epidural, the crescent or the banana shape you can see in, but the subdural, right? Blood in sulci or cisterns you can see in subarachnoid hemorrhage, and other than that ICH you can see blood within the brain tissue here also, like that. Okay, sorry, doctors. Yeah. Okay, I hope you get the idea. That is very important. Important. Okay, then other than that, we have different signs. We have the butterfly sign, the midline shift, the sunset sign, and the sunset sign, those things. Okay, I'll explain. It's very important. Okay, here. So, yeah. Next, you have to understand about the stroke, right? A stroke. How these strokes are present. Stroke also we can associate with different features, right? So, anyway, if you are suspected stroke, initially what you are doing non-contrast CT, right? Why you need to exclude a brain hemorrhages first, right? That's why you are initially doing this non-contrast CT, right? Okay, here. CT signs what? Loss of gray white differentiation, Loss of insular ribbon, sulcal effacement, hypertenuation, hyperdense artery sign. Though, what are those things? What are those things, doctors? Okay. Early ischemic stroke. What you can see. What you can see. Loss of gray-white differentiation. So gray cortex appears similar density to the white matter, right? So loss of gray-white differentiation, right? So that is a one thing. Then loss of insular ribbon. So what does that mean? So the insular cortex become less distinct. Right? Then these sources become compressed or less visible. These are getting compressed, right? This sulcal effacement means they are getting compressed and their differentiation can't visible on. I will explain from a one example, okay? Then hyperdense MCA sign. I will explain that one as well. Okay, so here, yeah, I don't think they will ask from that. But you need to understand this one. MCA, tertiary ischemic stroke, very important. So, what you can see, MCA occlusion. So, middle cerebral artery, that is very important stroke. Okay, here. What you can, if there's MCA occlusion, reduce cerebral blood flow, right? Then ischemia, cytotoxic edema, then the infarction. This is the pathophysiology. So the CT appearance change as the stroke evolves. So non-contrast CT, initially CT study in suspected acute stroke, the general knowledge. Okay, the important immediate questions are, is there a intracranial hemorrhage, early signs of ischemia, the large established infarct present, or is there a significant edema or mass effect? Okay, here. Okay, so let's see what are the things that you can see in these strokes. Okay, so what are the hyperdense MCA sign? So hyperdense MCA, middle cerebral artery sign. What is that? MCA appears abnormally bright. Why? What does that mean? Thrombus within MCA, right? So you can see this MCA, what? Like a very bright, because it's a blood clot in there, right? So very bright clot in this MCA, right? MCA here, I think there's a picture, but not very clear. Here, thrombus in the middle cerebral artery cause it to be appears hyperdense bright here, suggests acute MCA occlusion. Okay. So that is the one thing. The general thing is like you need to understand what is the bright white mean, the blood clot here mainly, right? If they have given the presentation with stroke and the arteries, those things, then think about there is occlusion, right? There is occlusion. Then loss of insular ribbon. What does that mean? Insular cortex become poorly defined, right? That means insular cortex become poorly defined, right? So need to understand, you need to know the anatomy, right? Anatomy here. The other features obscuration of lentiform nucleus. The lentiform nucleus lose its normal outline. So that means early basal ganglia ischemia present, right? So here loss of gray-white differentiation, cortex and white matter become difficult to distinguish, right? So both are getting in the same color because of the cytotoxic edema, right? So sulcal effacement means that those become narrow and disappear because of the swelling. I'll show pictures because these are not good, because I got this from this is like a AI picture. Okay, that's what I'm telling you, to don't use these things. I want you to like get the idea, like a general idea, but don't use these things. I will explain from the other pictures I got from internet. Okay, I want that the picture properly. Okay, here. So here, can you see the sulcal effacement? Can you see sulcal effacement because of the edema, and these sulcals are getting narrowing, and like you can't differentiate, right? Here the normal side you can see the sulcus appearance, right? Here can you see the sulcus appearance here? Can you see? But here the appearance, the differentiation has gone, right? Can you see the difference? This is the things. Then what is this midline shift? Can you see the midline shift? So in the middle, there should be those ventricles, right? Those ventricles. But because of this edema, the pressure, they are shifting, right? Midline is shifting to other side. So can you see it right here? Because of the edema, right? Okay, those are the features that you can see. And here the midline shift here. Here also it should it's supposed to be here the ventricles, but it's going to one side, right? Here the blood pushes the brain in an enclosed space. Here effacement of base assistance and the loss of like basically think they have lost everything like the differentiation, the sulcus and the midline, everything has shifted. Why? Because of this blood can push it, and because of that you can see it due to the tension. The same thing. Okay, same thing when we consider. Then we'll discuss about the hydrocephalus. Just remember those features, but I have not seen they have asked about this in the CT exam. But hydrocephalus they can ask. So what you can see the enlarged ventricles, right? You have to look at the lateral ventricles, the third ventricles, and the fourth ventricles. You can see it, right? You can see it, and we call it sunset sign. Sunset sign. But I can't see any sunset here. So just remember the dilated, the enlarged ventricles, right? Ventricles. Okay. Then what about the cerebral atrophy? Cerebral atrophy, what are the things that you can see? Is cerebral atrophy side, and this is the healthy side. So widening of the cortical sulci here. So the sulcus are widening, right? Enlargement of the ventricles. Here also you can see the enlargement of ventricles. Thinning of the cortex, right? The cortex are getting thin, right? Here. And the shrinking of the hippocampus, right? Hippocampus. These are the things that you can see in the cerebral atrophy, right? Here enlarged cortical so we'll see then enlarge ventricles and increase CSF space. You can see, right? Okay, so how you should differentiate hydrocephalus versus cerebral atrophy, because both has what? Both has big ventricles, right? The dilations can be present. So if it is big ventricles with big sulci, so you can think about atrophy, right? So with the big ventricle out of proportions to the these sulci, so in that case you can think about hydrocephalus is only the ventricle dilatation without other involvement of these sulcus, right? But if it is atrophy, that's the sulcus also involved, right? And other things you need to understand how these the cancer, the glioblastoma, the meningioma, the brain abscess, and the brain metastasis, how those things present, right? So let's first discuss about the glioblastoma. Glioblastoma origin is intraaxial primary brain tumor at intraaxial. Here, location is the cerebral hemispheres can cross the corpus callosum, right? And so here enhancement, irregular, thick, heterogeneous ring enhancement you can see here. And the center necrosis is common here. The surrounding edema you can see here. And here the special clue is can cross the corpus callosum, and you can see the butterfly glioma. So how this present the butterfly glioma? Here, the high grade astrocytoma. Here, IDS mutant or glioblastoma. Here, you can see like the butterfly, right? Here, it's not like actually butterfly. I don't know why they are telling it as a butterfly. Like, I think because they are crossing this middle part, right? Because of that here. I'll show here. This is the part they have given in image. See, glioblastoma is the most common malignant primary brain tumor in adults, but less common overall than meningioma. It is aggressive tumor with poor prognosis, typically present in the old adult with rapidly progressive neurological symptoms. Here you can see the irregular mass, heterogeneous enhancement, central necrosis, extensive surrounding edema, the mass effect, and it can cause the corpus callosum giving the butterfly appearance, but not in all the cases. Okay, not in all the cases. Butterfly glioblastoma. Yeah, because once it's cross it, then you can call it the butterfly. Otherwise, like if it is like separately present, you can't call it the butterfly appearance, right? Here, it's not actually like a butterfly. Okay, we can think this is the part. Okay, like this, right? Okay, this is the butterfly strand. Okay, okay, I made the butterfly here. Now, no problem. Okay, the butterfly appearance when cross the corpus callosum. But in here also you can't see here also the glioblastoma irregular middle necrosis is the glioblastoma. Okay. Then what about the meningioma? Meningioma, this is from e-medicine. It's a primary brain tumor classified on their cell origin. With the meningioma is the most common type in adult. Very important. The meningioma is the most common type in adult. Approximately 30% of primary brain tumors they arise from the arachnoid cap cells, and the meninges are typically slow growing and benign, though their clinical impact can be significant depending on the location. The epidemiology of the brain tumors show the significant age and gender variation. Meningioma more common in women with a female to male ratio 2 to 1, at their incidence increase with age. The peak age of diagnosis between 50 to 70 years, right? Okay, very important. The what you can see in here. Okay, and you can see in the meningioma. Here it's extraxial tumor with the meninges, usually single, typical location along the dural show. Okay, enhancement strong, usually homogeneous enhancement. You can see center is usually solid, but here the necrosis, the surrounding edema can be marked here. Dural tail extraxial appearance. You can see. Okay, here I'll show. This is a brain tumor, like it's not like very specified, like just a brain tumor. Okay, here you can see the background edema, and it can be the associated with the mass effect, right? Here the shift also can be seen because like brain tumor can cause those all of these stroke features as well. Okay, meningioma extra axial mass well circumcised, strongly enhancing, and here. Can you see the large right frontal apical meningioma here? Here, can you see the meningioma doctors here? Like this, okay? Okay, glioblastoma we just discussed. Okay, brain metastasis, how it present? Brain metastasis is like a multiple lesions commonly lacerated around the gray-white matter junctions. Here you can see the brain lesions here. Here the after contrast you can clearly it visible here. The brain metastasis. Okay, there should be in the questions they are mentioning the non-malignancy multiple brain regions, so you can think about metastasis. Okay, how the brain abscess present. Brain abscess contrast CT MRI may show ring enhanced lesion with surrounding edema, right? We call it dual rim sign. A outer low signal intensity rim, then inner high signal intensity rim, like that. That's what we call dual rim sign, right? Dual rim sign. And a patient can be present with the fever, headache, focal neurological deficit, seizures, source of infection. Important ring enhanced lesion is not automatically an abscess. Differentiation, abscess, metastasis, high grade primary tumor. So because these are like associated with like all of things are kind of same, right? But here you can see the dual rim sign in here. You can use the dual rim sign. Okay, how the cerebral contusion present usually occurs after the trauma. CT may show the patchy hemorrhage, edema, mixed hyperdense or hypodense areas, commonly frontal lobes, temporal lobes, right? So here you can see CT scan shows the cerebral contusion, hemorrhage within the hemispheres, and subdural hematoma on the left, and the skull fracture. Here, I think here's the skull fracture, very not very clear. And here you can see hemorrhages, but not very clear because I couldn't find. This is the only picture I could find, like better, like kind of better than the given one. This is from the Wikipedia. Yeah, Wikipedia. Here you can see the fracture as well. That's all, doctors. Like if you are not, don't think too much about the stroke because if you know the like clinical presentation how it present, they are not usually asking for the CT, but for this one the hematomas, the brain hematomas, that part they are asking from CT, and the tumors and the abscess they are asking, but not mostly from the strokes, right? Okay, that's all for the this part. CT head, like a general, very simply I explained. So we'll quickly go through these pictures. Okay, I'm not going deep inside these things, but I'll like explain how it presents. So how the melanoma present? Melanoma present with how? Melanoma. How melanoma present, doctors? We have what? A, B, C, D, E, right? We have asymmetric lesion, right? Irregular borders, right? The colors can be different, right? The diameter usually more than 6 millimeter, right? And I mean the evolving lesions you can see, right? I hope everyone know those things, right? Here you can see. Here melanoma. Here is a superficial melanoma. Because melanoma also we have different types, right? Here we have superficial melanoma, we have nodular melanoma, acral lentiginous melanoma. Acral lentiginous means usually can see in the palms, also nails, right? And the lentigo melanoma, it's like a benign type, right? Even melanoma like a high risk case, but the lentigo melanoma, those are like low risk, right? Low risk, but it can be converted into the malignant melanoma as well. Because of that, you have to make sure like to identify the type of melanoma very clearly, right? Very clearly. Okay, here, what is this? Is amelanotic melanoma. Amelanotic, okay. The color has no, there's no color. Amelanotic melanoma refers to melanoma that are pink, red, or flesh color. They are usually harder to tell apart from the other skin condition. So, as a result, amelanotic melanoma usually diagnosed later compared to other types. Right, the amelanotic one as well. Yeah. Okay, here melanoma in the mucosal melanoma, and here acral lentiginous melanoma. This has asked in June, right? Acral lentiginous melanoma, and here the every month they are asking about the ophthalmic case, right? The large melanoma in the eye, right, or in sclera, right? They are asking if anyway once you see the melanoma in the eye, inside the eye, it's always the either some referral, right? The plastic surgeon referral or ophthalmologist referral. Okay, so like generally, what is the initial things once you are suspecting a melanoma? What you need to do? Tell me, doctors. You have to do the excision biopsy, right? Excision biopsy, that is very important. Once you're suspecting excision melanoma, you need to do the excisional biopsy, right? After excisional biopsy, no, okay. If the okay melanoma is a there's a melanoma in a, we are suspecting it's as a melanoma. It's a large lesion on the cheek, a large lesion. In that case, what you do? What do you do? Which type of melanoma is the excisional biopsy? Or what you need to do? In that case, you have to think about other type of biopsy, right? Like a punch biopsy or shave biopsy. But mainly they are mentioning the punch biopsy is better, right? Punch biopsy is better. So in that case, you have to always think, right? Where's the area? Okay, whereas the area is presenting with this melanoma, if it is a cosmetically sensitive area, you are not going with the excisional biopsy. Okay, after doing the biopsy, what you need to do? After the biopsy, what you need to do, doctors? After biopsy, how you should treat? Hmm? Am I offline? Okay. Here what you need to do, doctors, to do the treatment, right? The large excision, wide local excision you need to do, right? Here the initial excision exclude the confirm the diagnosis. So initial excision to confirm the diagnosis, right? To send the details, send this excision, the biopsy to the histopathology service, and you have to get the result, right? After confirming here. So initial excision should be done with 2 mm lateral margin, right? I show someone has mentioned like 3 to 4 centimeters. Not 3 to 4 centimeters, it's like 2 centimeters. Sorry, 2 mm, not centimeter. 2 mm lateral margin, right? Preferably as a ellipse, right? So, like partial biopsies, you are going with what? If it is in a cosmetical sensitive area. Okay, if melanoma confirm, you need to do the wide local excision within 4 weeks, right? Within 4 weeks. So, definitive treatment is depend on the thickness of this melanoma. So, if it is in situ, excisional wide local excision with the 5 to 10 mm margins thinner than 1 mm, 1 centimeter margin, 1 to 4 mm thickness, 1 to 2 centimeter margin, and if it's thicker than 4 mm, excision should be done with the 2 centimeter excisional margin, right? I hope you get the idea. Yeah, it's very important. Okay, so what do you know about BCC, basal cell carcinoma? How basal cell carcinoma present? Basal cell carcinoma usually present as what? It's a slow growing, right? Pearly nodule, telangiectatic vessel, right? Road ledges you have seen, right? Pearly, shiny. Ulceration is also common in some cases, the middle ulceration. The nose is often common side due to the chronic sun exposure. The patient's history, yeah, not this one. Okay, here can you see the typical presentation? Typical presentation. And okay, and I want to explain another thing. Okay, if it is because in emergency for the lentigo melanoma, very important. Lentigo melanoma, they have given some scenario we can just observe, right? We can just observe in that what case can we observe, in what cases can we observe the melanoma. If the lentigo melanoma is not associated with these features, in that case we can just follow up. We can just follow up the melanoma, lentigo melanoma only. Okay, not for any other melanoma, just for the lentigo melanoma, because it's like a very low risk, right? If you are not remember, just do the lentigo melanoma. I think there's around 8 or 9 questions. Do those things, then you will understand. Because like you need to know, melanoma, once the lesion is having the warning sign. Warning signs are never changing. As example, there are some questions. The patient is having some face lesion for 5 years. 5 years without having any problem, like no itching, nothing. But recently the patient has noticed there is some kind of itching on that lesion. In that case, what you need to do, you should not wait. You should not wait for the follow up. In that case, you need to know that is a warning sign, right? Never change it, right? Prominent or pigment or standard out like a mole. Rapid growing or particular concern to the patient, atypical dermoscopy, change on sequential dermoscopy. The particular concern to the patient because there's a itching present, right? There's a new symptom is present on the lesion because earlier it was not giving any symptoms. In that case, you need to do the biopsy and understand is there the malignant features present or not, right? Because of that, these points are very important, right? Very important, especially when we are discussing about the lentigo melanoma and AMC is one of favorite hot topic. Okay. Okay, so yeah, then what do you know about BCC, how it present? And BCC also, we have different types of BCC. Here also another BCC old age, right? Central telangiectatic, right? So those things can be shiny papules, slow growing, sun exposed area here. Can you see? So what's the management of BCC? What is the management of BCC? What is the management of BCC, doctors? We have two types of basal cell carcinoma. When we are discussing the treatment, we have superficial basal cell carcinoma, and we have what? We have other basal cell carcinoma than superficial, right? Here. So what you need to do? Here, the treatment for the superficial basal cell carcinoma, you can use imiquimod 5% cream, right? Or you have the liquid nitrogen cryotherapy, and you have the photodynamic therapy, cryotherapy, but mostly in the emergency also they have asking from this imiquimod 5% cream topically, okay? In this case, if they want to go in with the superficial basal cell carcinoma, if it is all other than superficial basal cell carcinoma, first line is what? First line therapy is you need to do the surgical excision. Why? You need to get the biopsy and diagnose it properly, right? Because these are like very small lesions, so you can do the biopsy with the margin 3 to 4 millimeter, right? 3 to 4 millimeter, and you can totally doing the surgical excision and take the samples and do the histopathology, right? Because it's not a large lesion, right? I hope don't confuse this thing. I saw one doctor has shared 3 to 4 millimeter in for the melanoma, okay? But it's associated with the basal cell carcinoma, right? Basal cell carcinoma, and basal cell carcinoma, you need to understand other things as well. When to go with the other options like this, the more microscopic surgery. If it is infiltrative, morphic, or micronodular subtype, poorly defined, such as that extent of the tumors incidentally clinically located when the tissue conservation is important, like in nose, eyes, lips, central facial area. In that case, you refer this patient for the micrographic surgery, right? It's a very important thing that you should never miss. I'm just quickly explaining, okay? Yeah. And there's one question in e-medicine. There was a patient, okay, patient with COPD, and patient is wheelchair bounded, patient COPD, like severely COPD, patient can't breathe, and patient is having some BCC suspicious lesion on hand. In that case, what you can do? So options are watchful waiting. And other than the surgical excisions, the patient is having congestive heart failure as well. Yeah, in that case, please remember that question. BCC on a hand with the multiple comorbidities, and patient is like bed bounded or wheelchair bound in those cases, because BCC is like a low risk and it's situated on the hand. We are going with the watchful waiting, right? Watchful waiting. Why? Because the patient is very elderly. There's no point of going with the invasive things for this kind of patient, right? So those are the extra things that they have given in e-medicine. You can only understand and once you are doing the questions, otherwise you can't understand those things, okay? So what do you know about squamous cell carcinoma? Squamous cell carcinoma, they are skin every time, because we have different types of squamous cell carcinoma. What are those types? We have squamous cell carcinoma in situ, right? So what is that? The Bowen's disease. Right, we have invasive squamous cell carcinoma, we have keratoacanthoma, right? So these are the main things that you need to understand. So what is this Bowen's disease? Bowen's disease is squamous cell carcinoma in situ. Bowen's disease. Tell me, doctors, what do you know about the Bowen's disease? Bowen's is a squamous cell carcinoma in situ, right? It also keratinocyte malignancy, but it's only in the epidermis and not invade the dermis, right? It's like a superficial thing, right? So due to these chronic UV exposure, right, old age, immunosuppression, those things like HPV, those things that they can be present. Right, so how it is a slow growing, right? The slow growing one, even though like SCC are like rapidly growing, but this is a squamous cell carcinoma in situ, right? The benign disease. Bowens is a benign one. In that case, they are slow growing, right? You can see the well demarcated red pink scaly plaque, right? Scaly plaque, right? And usually it can be present like this and not healing, right? Maybe it can be crusted like this, right? Sometimes there can be itchiness also present, right? So what is the management? The treatment of SCC in situ from the other SCCs. So we have what? We have topical field treatment like fluorouracil, imiquimod, right? And other than that, we have cryotherapy, curettage. But like go with these things, fluorouracil or imiquimod, very important. Okay. Then we have invasive squamous cell carcinoma. Invasive squamous cell carcinoma, can you see it's like a rapid growing squamous cell carcinoma and the second most common cancer in the Australia, right? Okay, then okay. A squamous cell is the picture. Okay, then okay, the treatment, invasive SCC more rapidly than BCC should treat it with as soon as possible. Here, the complete surgical excision with 3 to 5 margins, right? Don't confuse the centimeter. 3 to 5 margin initial excision, then you have to send the details for the histopathological reveal, right? Then you have to treat. Then, for a primary invasive SCC where the surgery is contraindicated, advanced age comorbidities, or likely to result in significant morbidity or the scarring, you have to consider specialist referral for the consideration of the radiotherapy, right? So post-operative adjunct therapy is recommended for SCC that have high-risk metastasis. The margins are positive. Histopathology shows the poor differentiation and other high-risk histological subtypes. Then depth of the tumor greater than 4 millimeter. Tumor is more than 2 centimeter in diameter. And the recurrent SCC case and high risk side. Okay, in these things you can think about radiotherapy. One minute. Post-operative radiotherapy, okay, to reduce the recurrence and those things. Okay, this keratoacanthoma has asked in July, right, doctor? July or June? I can't remember. Either July or June. July, I think. They have asked about the keratoacanthoma. So, keratoacanthoma, that is a squamous proliferative tumor that presents in the nodule with the keratonic plug, right? You can see the keratonic plug here. Keratic plaque. So what is the treatment for this one? And this is a rapidly growing one. So what is the treatment, doctors? What is the treatment? Can you see the keratic plaque? You have to do the complete excision, right? Complete excision you need to do. Okay, right? You need to do the complete excision. Okay, doctors, is it understandable, right? So we'll go back to, I'm just explaining too much. I don't know you need this or not. Because I feel like these skin cancers are very important. Okay, very important. That's what. Yeah, these are the pictures. Yeah, SCC on the lip and the Bowen's disease, the keratoacanthoma, the keratic plug. This is the image picture that they have. I think this picture was the one came the SCC on the nose. Sorry, the keratoacanthoma on the nose. And other things. Here also keratoacanthoma. Okay, actinic keratosis. So, what do you know about actinic keratosis? It's very important because this time, oh, June, I think July, they have asked the actinic keratosis. The exact image equation they have asked. They have asked for the actinic keratosis, this picture. So, what do you know about actinic keratosis? What is actinic keratosis? Or solar keratosis? What is it? Okay, it's a pre-malignant lesion, right? So it's a or sunspot. There are erythematous and scaly lesions found in the skin area, usually exposed to the suns, right? Backs of the hand, forearm, face, scalp, and in the bald people. Lesions are ranged from size to 2 to 20 millimeter in the diameter and often occurs in multiple known as the field change of field cancerization. Actinic keratosis are usually asymptomatic but sometimes can cause itch, irritation, or pain, right? Here. So, how it present? How it present? It can be atrophic, hypertrophic, pigmented, or lichenoid. There can be mimic superficial basal cell carcinoma, hypertrophic actinic keratosis can be mimic squamous cell carcinoma. Here you can see. So what are the treatment? Actinic keratosis can be made spontaneously, particularly with the vigilant sun protection. The treatment is not usually necessary, but the indication for active treatment if this includes symptomatic lesions, cosmetic reasons, multiple extensive field keratosis, which invasive disease cannot be excluded. So what you can see, you have the topical field treatment. So what you can use? You can use the topical fluorouracil, reduce the risk. I mean, many treatments are available for the actinic keratosis. The choices depend on the patient's lesion. Right, the first line therapy is non-extensive actinic keratosis, the cryotherapy with the liquid nitrogen. Most actinic keratosis respond well with the cryotherapy. However, avoid cryotherapy if the diagnosis is uncertain. Curettage or shaving excision produce the good results in selected cases. Extensive or multiple field actinic keratosis. Intolerance to cryotherapy, you can use the topical field treatment, right? We have the fluorouracil or imiquimod. Okay, like that here, the fluorouracil or imiquimod, right? So yeah, keep this picture in your mind. Here also, can you see? Usually they are giving €5, five fluorouracil or imiquimod mainly, not the cryotherapy. Okay, I have seen these things in e-medicine. Okay, here what about the seborrheic keratosis? So what do you know about the seborrheic keratosis? Here can you see it has a waxy appearance, right? These are benign epidermal tumors that commonly occurs in all adults. Typically appears as well-demarcated brown or black lesions with waxy appearance, right? Which matches the here. Can you see the waxy appearance here? Can you see the waxy appearance here, like wax? Seborrheic keratosis. Can you see? Okay, do not need treatment. Okay, very important. Do not need treatment. Because the lesions are not pre-malignant. Okay. However, the treatment can be considered for the cosmetic reason, for the recurrent inflammatory lesion. For the treatment, destructive methods like cryotherapy you can use. So, shave excision, curettage, diathermy, or ablative laser excision is rarely needed. Right. Now, these are not pre-malignant. Not pre-malignant. Okay. Seborrheic keratosis not pre-malignant. Okay. Here also seborrheic keratosis. Here. Okay, what do you know about the pemphigus foliaceus? Foliaceus. What is pemphigus foliaceus? This appearance. This came on November. Yeah, November. What do you think? Here, pemphigus foliaceus. What is autonomic blistering of the skin disease? Antibodies against the desmoglein 1. Superficial fragile blisters that rupture easily. Superficial fragile blisters that rupture easily. Right? Crusted or scale erosions, no mucosal involvement, Nikolowski sign positive. That means when gentle lateral pressure on the normal appear in the skin cause the epidermis to shear off, forming an erosion. Treated with the systemic steroid and immunosuppressions, right? Uh, pemphigus foliaceus. Then what do you know about the seborrheic keratosis? Seborrheic keratosis. Here the benign epidermal tumor, common in older, well demarcated. So because that they have given in the picture of the back, this one, and that's what I have attached this how seborrheic keratosis also present, right? We just discussed. So how atopic dermatitis present? Can you see the pictures? Atopic dermatitis. How present atopic dermatitis, doctors? Atopic dermatitis. What is atopic dermatitis? What is the presentation atopic dermatitis? Okay, usually develop in the first year of life, but can be present for the first time in the adults. Most children experience remission, substantial improvement of their topical dermatitis before starting the primary school. Here it can be affected on the any area of the skin, but typically occurs on the face, cubital, and the popliteal fossa behind the elbow and knees, with an ankle and hallmark of atopic dermatitis itchy, right? Itchy. They are itchy, right? Okay, so why this atopic dermatitis present? What is the reason? Why? What is other name? Other name is eczema, right? It's inflammatory skin condition, right? It's due to what? Skin barrier dysfunction. Right, doctors? Okay. I usually associate with the atopy, right? The asthma patients, right? The patient with allergic rhinitis, right? Patient who is having those food allergies, right? Because this associated with the atopy, right? Atopy. And the what are the symptoms? There are, right? Dry skin, erythema, right? This pruritic skin, pruritic patches, excoriation due to the scaling, right? Scratching, right? And yeah, those are the main things that you need to understand. In the children, you can see the flexure surface, right? Flexure surface. In the adult, flexures, hand, face, neck, those things can be associated. Right? Okay, can you see the pictures here? Okay. So, summary of management advise patient to improve the skin conditions, identify avoid the aggravating factors. There are areas of inflammation with the topical corticosteroid with modified dressing, right? Or oral corticosteroid are really appropriate because rebound flares can occur when they are stopped, right? Yeah, those things are main things. Yeah. Okay. We don't have time to go with all the details. So psoriasis. So psoriasis, you need to understand. We have different types of psoriasis, right? We have different types of psoriasis. What are those different types? We have plaque psoriasis, right? We have plaque psoriasis. So what is the psoriasis? It's a chronic immune-mediated inflammatory skin condition, right? Skin condition with what well-demarcated erythematous plaques you can see here, right? And we have the scales here, right? Scaly plaques, right? It's scaly plaques. So we have silver white scale, right? Silver white scale, and usually here auspit sign says positive. So what is auspit sign here? Auspit sign mean what here? Okay, once you remove this scale, there can be a pinpoint bleeding. Can you see once you remove this one, there can be a pinpoint bleeding that we call the auspit sign, right? Yes. Yes, you can see the pinpoint bleeding. And yeah, what are the usually can mainly see in the extensor surfaces, right? Elbows, knees, right? Elbows, knees, those things. Then, and other than some cases, they can be associated with the nail pitting, right? Onycholysis and the nail discolorations, those things can be associated, right? And we have different types, the chronic plaque psoriasis, gouty psoriasis, right? Flexural psoriasis, pustular psoriasis, right? Scalp psoriasis, a lot of types of psoriasis. And we have what psoriatic arthritis as well, right? Patient with this psoriasis, they can be present with the arthritis, right? Joint pain, swelling, right? Morning stiffness, dactylitis, right? The back pains, and those things can be present. Okay, so here this is the one psoriasis on limb. Can you see the pictures? Okay, this is picture image, and here can you see the scalp psoriasis here? The scalp psoriasis, the typical presentation, and this is a hyperkeratotic psoriasis. Hyperkeratotic psoriasis. Here can you see the pustular psoriasis? Here you can see pustules here, yellow color the pustules, right? Yeah. Then you can see the gutati psoriasis, right? Gutati psoriasis. Then, okay, so what do you know about the tinea infection? What do you know about the tinea infection? What do you know about tinea, doctors? Tinea. It's a dermatophyte fungal infection, right? Dermatophyte infection, right? It's a dermatophyte, right, doctors? So mainly associated with the skin, hair, and the nails, right? Skin, hair, and nail, right, doctors? So what is a common organism? Trichophyton, right? Trichophyton. Trichophyton is the common organism, right, doctors? So here. So yeah. Okay. Let's see. Okay, what are the classic presentation? How it present? How it present, doctors? How it present? It has the annular erythematous scaly plaque, right? Annular erythematous scaly plaque. Here, can you see? Mm-hmm. And you have this raised active scaly border. You have the active. Okay, I'll show a better picture. Okay, here. What can you see here? Annular erythematous scaly plaque, right? Then you have raised border, right? Raised border, right? Central clearance you can see. Central clearance, right? Central clearance you can see. Very important. Central is clear, right? And this is the annular erythematous scaly plaque, and we have the bud raised border, right? Raised border, right? And here this is very itchy. And this is very itchy as well. Yes, okay, so that is one. And we call it according to the type, right? The tinea corporis, right? Corporis and tinea capitis, tinea cruris, right? Tinea unguium, right? Tinea barbe, right? Barbe, right? So tinea corporis mean what? The body, right? The body area, right? Because you can see the annular ring-shaped lesion. So tinea cruris mean what? In the groin area, right? Cruris groin area. Then tinea pedis, you can see it especially in the feet, right? The tinea capitis, scalp scaling, right? Hair also broken hair. You can see the tinea capitis. I'll show the pictures. Tinea unguium, onguium, right? Onguium, but you can see in nails, right? Nails, you can see this. Okay, tinea barbara in the beard area. Here, can you see? Beard area. Here also tinea in hand, not very good picture. Here you can see in the leg. Here tinea capitis, you can see. Can you see? Yeah. Okay. So what is pyogenic granuloma? Pyogenic granuloma. What is pyogenic granuloma? What is it? It's a capillary hemangioma, right? Capillary hemangioma, right, doctors? It's a benign vascular proliferation, right? Benign vascular proliferation. Mm-hmm. How it present? It's due to what? Due to the minor trauma, right? And it can be associated with the hormonal changes in the pregnancy, right? And the pregnancy and the other hormonal changes. And it can be due to the medications, right? Sometimes can be idiopathic, right? Okay, so how it present? It's a rapidly growing, right? Rapidly growing lesion, right, doctors? So it has the bright red, right? Bright red color lesion, right? Bleed very easily, right? Doctors bleed very easily, right? That is a very important presentation. Bleed very easily even after the minor trauma, right? Like that. This is the typical presentation. What you can do, you have to remove this from the doing excision, right? You can do the excision and remove it. Okay. Mm, Now tell me about the pityriasia rosea. What is pityriasia rosea? Tell me, doctors, what do you know? What do you know about this disease? Okay. It's what? It's inflammatory skin eruption, right? Usually can be start in young adults, right? Or doesn't, or the young adults, right? So we have different presentation, right? One is, what is the one? The herald patch. So what is herald patch? So what is this herald patch? This is the herald patch. This is the herald patch. So what does this herald patch mean? Herald patch. Okay, so usually this disease is starting with this herald patch, right? Herald patch is a single patch that appears before the generalized rash of Idrisia rosea. It is a slightly raised oval salmon pink red plug 2 to 5 centimeter in the diameter with the peripheral scaly trailing just inside the edge of the lesion like a collarette, right? So then after that there is a secondary rash, or we call it what is the name of the rash? We call it Christmas tree rash, right? Christmas tree rash, but not very visible. Can you see like this? So that's what we call it, Christmas tree rash. Okay, Christmas tree rash. Here you can see it's like a Christmas tree rash, right? Christmas tree. Secondary rash, smaller patches develop over the beak or toe, spreading across the trunk and sometimes the arms and legs, right? So, and other than that, myelin can be present, generalized malaise can be present, right? Can be present. Okay, is it understandable, doctors? This is understandable. And it is self-limiting inflammatory skin condition. Okay, caused by viral infection, reactivation of human HP, human herpes 607, right? Okay, so yeah. Next one, the scabies. How scabies present? How scabies present? You can clearly see what? Scabies burrows, right? Scabies burrows. Can you see like a thread-like appearance? This is a burrow. Here, this is a burrow. These are the burrows, right? Here, these are the burrows. It's a very pathognomic, right? It's a very pathognomic for this one. And other than that, the patient needs can be associated with the scaling, right? Scaling and the itchiness, and those things can be present with the scabies. So other than that, what are the features? Nocturnal itchiness, right? Then what else? Tell me, doctors, what is the typical presentation of scabies? Because every month this is asking. What is the presentation? So what you can see the red color, these papules, right? Like these things, papules. Then excoriation, the pathognomic burrows, right? Those things can be seen. Okay, okay. So yeah, next one. Okay, next one, impetigo, how it present. We have impetigo two types, bullous and non-bullous. So what is the severe case, bullous or non-bullous? Severe one, bullous or non-bullous? Minute, tell me. What is the severe case, bullous or non-bullous? Bullous one, right? Okay, bullous one associated with what? What other than the other than skin manifestation? What are the other features? It can be associated with the systemic features, right? Systemic features. So non-bullous, how it can present the honey crust, right? Honey crust appearance you can see, right? Here most commonly in the face and extremity, but skin is on the part of body can involve benign with the single erythematous macules which involve the pustules or vesicles, then later that become into the honey crust, right? Honey crust appearance here. Okay, honey crust. What about the bullous one? Can you see the honey crust here appearance? Honey crust appearance very important. Then yeah, here the bullous impetigo. Bullous one is the kind of severe than the non-bullous one. Bullous can be associated with these skin manifestation that can be associated with these ulcerations and these erythemas and kind of deep wound. Here usually found in the face, trunk, and buttock or perianal area. Can spread distal due to the autoinoculation. Quickly appear superficial, small or large Roofed bulla which tend to spontaneous rupture and whose yellow fluid live in the scaly rim and having systemic symptoms, malaise, fever, and lymphadenopathy. Here, crusted vepilation. Here, facial impetigo. It's kind of severe than the non-bullous one, right? The treatment can be very different for these two, right? Okay, treatment is depending on the impetigo according to the what? According to what the treatment depending on impetigo? According to the type of the lesion, right? Type of the lesion and number of the lesion. What is other than that? Type of the lesion, number of lesion, then if patient is having systemic features or not. Okay, not the word severity we can tell. You need to tell exactly how according to the number of lesion, right? According to the extensiveness of the disease, right? According to the patient is having systemic features or not, right? Here, the bullets one, large floppy blisters, rapid developing erythematous, shallow erosions, right? Systemic symptoms, malaise, fever, more likely than with the non-bullous impetigo. Bullous impetigo usually caused by Streptococcus aureus, right? The honey crust appearance, here you can see the extensive erythema. The treatment, if it is a, okay, treatment like this. Patient is having another other point is a recurrence, right? Patient is okay. Lesions are the source are up to two and no high risk factors for rheumatoid fever and the no systemic features, no recurrence. In that case, you can use the topical treatment like mupirocin or hydrogen peroxide, right? So empirical therapy with these oral antibiotics when to use decloxa or flucloxa if the patient is having extensive disease, more than two lesions and the or recurrent disease or the bullous impetigo. In these cases, what you have to think? How to think about giving oral antibiotic, right? Decloxa, flucloxa, and we have the cephalexin if the patient is having hypersensitivity to these penicillin, but we prefer cephalexin in the children because it present in the liquid formation, and it's easy to use in the pediatric population. Okay. If you are familiar with this question, you know, right? Here, the answer is what oral cephalexin. Yeah, excellent. Okay, so erythema multiforme. This question has asked on, asked on July, right? Erythema multiforme. How it presents? So, what is it? It's an immune mediated, typically self-limiting mucocutaneous lesion characteristic by target lesion, or you can call it like a donut lesion. You can remember it as either target or donut. It significant mucosal involvement distinguish the erythema multiforme major from multiforme minor. Episode can be isolated, recurrent, or persistent. In most cases, erythema multiforme is precipitated by the herpes simplex infection, and alternative triggers include the other infections, medications, and vaccinations. Specific target lesions present as concentric rings of the colors, right? Okay. So erythema nodosum, I recently also explained what is it. It's a paniculitis, right? Symmetrical. You can see inflammatory paniculitis nodules, right? It's a painful, right? Painful, and it's like fat tissue inflammation, right? Can be associated with the TB, IBD, right? Yeah. Those are the things that can be associated. Okay, then what do you know about erythema marginatum? Erythema marginatum. Here you can see the most frequently involved site can also sites are trunk, especially abdomen, axillary, occasionally the limbs. EM is usually asymptomatic and the lesions more evident in the afternoon, fade in few hours or most 2 to 3 days, leaving pale or light pigmented macules. Recurrent crops and the occurs over the some weeks, often in different size. Subcutaneous nodule and the cutaneous criterium of pneumonia fever can be present in the minority of the patients with the right erythema marginatum. So it's associated with the rheumatic fever, right? So yeah, erythema nodosum and erythema multiforme. Very important, these three. So urticaria, where you can see the urticaria, doctors. It's a we call it the hives, right? Itchy wheels or hives with or without surrounding erythema flares. The name urticaria derived from the common European stinging nettle urticaria dioica. Urticaria can be acute or chronic or spontaneously or inducible. A wheal or a wheal. Superficial skin condition, pale skin swelling, usually surrounded by the erythema that lasts anything for few minutes to 24 hours. Urticaria coexisting with the angioedema, which can deposit with the within the skin or mucosa membrane. Right? Okay, herpes zoster. What do you know about herpes zoster? Herpes zoster is a localized blistering painful rash caused by the reactivation of varicella zoster virus, right? Herpes zoster also called shingles, right? So varicella zoster herpes virus 3 and the member of herpes order the double stranded DNA, right? So what is this? Yeah. So what you can see in this face? What you can see in this face? Tell me, doctors. What you can see in the face? Yeah, doctor, I will upload the recording, okay? Okay, okay. Okay, sure, doctor, no problem. 1 minute. What is in the chat? Okay, dermatome distribution. Okay. Mm-hmm. Here is a classic appearance. A base zoster. Okay, here. So, what dermatomal is associated in the face mainly? If it is associated with the ophthalmic division, the V1, right? V1 we called here herpes zoster ophthalmicus, right? Herpes zoster ophthalmicus, right, doctors? Right? Yes, that's what I was asking. So if it is associated with the facial nerve involvement, with the ear vesicle and the facial palsy, what we called facial nerve involvement, ear vesicle, facial palsy, in that case, what we call it's a Ramsay-Hunt syndrome, right? Ramsay-Hunt syndrome. Very important. Don't confuse things. Okay, what do you know about acne vulgaris? Here you can see the acne, right? Acne vulgaris, you must go through the TG. TG for the management because we have multi-moderate management and moderate to severe management. Everything is very important because we got this topic acne picture Mild or moderate case. I think mild case. Can't remember the exact one. We got it in the day 5 of July exam. Okay, the acne picture with the description exactly given in the e-medicine. Okay, mild case, I think, mild case. Because of that, you must go with this one because these are very important. Here you can see the mild, moderate, and the severe acne. Hey, this is the management. Okay, I have shared this one, this PDF in the group. You can go through that one. How mild acne manage and how moderate to severe acne is managed. And very important. Okay, very important. Then other than next topic is herpetic whitlow. So what is herpetic whitlow? Herpetic whitlow, doctors, what is it? And for the Ramsay Hunt also they have asked. For that, please remember this picture. Okay, very important. Ramsay Hunt syndrome, because this exact picture, the exact picture they have given the blue jacket lady, the blue jacket lady with this Ramsehana here. This is the picture. This exact picture they have given in the exam. Very important. Okay, very important. These things. Very important. Please keep in mind this picture. The Ramsehan, this blue color jacket lady. Okay, remember this one. Very important. This picture they are usually given. And this other picture, remember this one as well. You never know, right? Okay, can you tell me the management here? Can you tell me the management, doctors? I'm not going to read it. So you can see what Ramsay-Hunt syndrome, what is the management here? Quickly, quickly. August doctors, you don't have time. What is the management here? Okay, interesting. Mm-hmm. Okay, don't confuse things. Okay, patient present with the Ramsay-Hunt syndrome. So here, Ramsay-Hunt syndrome. Early treatment within 72 hours of symptom onset with the better outcome of the Ramsay-Hunt syndrome. Combination with the antiviral and corticosteroid therapy is the most effective treatment of Ramsay-Hunt syndrome. Very important. Very important. I have seen one doctor has choose A. So please, doctor, make sure you know this topic is came on July. As I remember, July or June. I can't remember exactly. Either July or June, we got this topic. Very important. Okay, very important. So the combination should be there, right? Combination should be there. Okay, so what do you know about this one? The herpetic whitlow. The herpetic whitlow is what? Herpetic whitlow. What you can see? Herpetic whitlow. What is in the fingers? It is what? HSV on the fingers, right? HSV on the fingers, right? Usually it from the herpetic whitlow, HSV1 and HSV2, right? So what you can see the swollen fingers, right? Burning sensation, right? So you can see the here like clear vesicles or like clear vesicles with these erythematous in these fingers. Yes, like a clustered vesicle due to the HSV and broken down into the erosions, right? After the broken down into these blisters, there can be erosions here. Can we see clustered vesicles here? Clustered vesicles, those things, okay? Very important. And so, how in the pediatric population, how this is happening? How children with what? Children with oral HSV due to the because they are usually sucking their fingers, right? Because of that, there can be inoculation, right? Auto inoculation. Because of that, these children are mainly having this herpetic whitlow, right? Herpetic whitlow. Okay. Yeah, very important. And what do you know about this one? Form-folix. This is another thing. Form-folix, very important. Uh, dishydrotic eczema, we call it, or form-folix. It's like a tapioca, right? Tapioca-like lesions, right? Sorry, doctors, I got this one from my own notes. When I was using, yeah, in the prepare, when I was preparing, it's like a tapioca, right? You everyone know like the bubble teas, right? They are like a bubbles, right? So tapioca like lesions. So in here, dyschondrotic eczema, form-folix, this came on December. It's a itchy, chronic, recurrent, often symmetrical eruptions of the palms of the hand, the fingers, and soles of the feet, characteristic by small, deep-seated 1 to 2 fluid-filled vesicles on these sites, which resolve after the several weeks of the scaling. So, debates exist around the precise terminology and definition, but the names of the condition include form-folix, acute and recurrent vesicular and hand dermatitis, acute uh, palmoplantar eczema, vesicular. Okay, just remember these two names: dyschondrotic eczema and the form-folix. Okay, very important. Very important. Okay, so how the molluscum contagiosum present? Because I have attached, because these three, this herpetic whitlow and the form-folix and the molluscum contagiosum on molluscum contagiosum, also three are like the same, like the appearance wise they are same. That's what I want to give this one, like to compare these things, right? So what you can see, they are painless dome shapes with central umbilicated papules right here. Can you see papules like this? Usually, this is self-limiting condition, right? Self-limiting condition. So, is there any school exclusion criteria for the molluscum contagiosum? Tell me, doctors, or the treatment. Tell me. No, right? Okay. Usually you can see in the pediatric population, right? Yes. Yes, you have to be very hygienic, right? Should not share the personal items, right? Yeah. The hygiene is the one that you should consider, right? Consider. Okay, next one. So oral thrush. Every time they are asking, right? Oral candidiasis. This is the typical presentation. And last time they have given some weird question in July, right? They have given something like recurrent oral thrush, oral candidiasis, and the patient is having some, can't remember, like recurrent case, and they have given like what to do next. So are we going with the biopsy, or like checking for the HIV or something like that? That question is very weird. If they have given the red flags for these candidiasis, in that case, you can think about going with the biopsy. Other than, you can think about the immunosuppression people like the HIV patients, or patient is having the diabetic, they are more prone to have this recurrent candidiasis. So, what's the treatment of choice for oral thrush? What is the treatment of choice for the oral thrush? Is an study in oral drop you can use, right? Okay, vaginal candidiasis. This is the image they are given in AMC. This is the picture that they have in their question bank. Okay, AMC, the typical exam question bank. So keep this, because I personally got this picture. I personally got this exact picture. So this is the vaginal candidiasis picture. Okay, you can see the cottage cheese appearance, right? If it is what? If it is a recurrent case, what you need to do initially, if it is a recurrent case, what you need to do, you have to test, right? You have to do the high vaginal swab and culture before starting the treatment. You have to confirm it. If it is the initial presentation and you are suspecting it as the candidiasis, you can start the treatment right away without doing the without checking for the high vaginal swab, right? So remember, these are very important points that you should differentiate different questions. Okay, only for recurrent cases, or like if you are considering the non-albicans species, right? So gallbladder, those kind of things, then you can do the you can check for the by doing the vaginal swab. Otherwise, if it is just a simple presentation, you can just start the treatment right away. Yes. Okay, these are the other, and like not always it present as the vaginal, the white cheese appearance. Not always present in like this. There can be a red brick appearance as well, like the Candida vaginitis, right? Red brick vagina, like the red colored inflamed vagina. Also, you can see, not all the time you can see the these red the cottage cheese appearance. Okay, yeah, that's all like I have attached in this one. So I hope you get a better idea about like overall, and we have covered a lot of topics, right? How was today's session? How you feel? How you feel, doctors? Is it useful? Like, because I have done it like a very super fast way. Because, yeah, okay, because I want to go quickly for the August doctors because they already know the theory. I just want to just remind it. Okay, that's all. Okay, so tomorrow, what do you want to discuss? Tomorrow, what do you want to discuss? Like a quick revision. I'm not going like deep inside because now it is not the time for doing the deep revision. We deep discussion. We just need to rapid revision for the August doctors. That's what I'm not taking other doctors as well. No. Thank you, doctors. Neurostroke effect, spinal cord lesions. Okay, that is only a small part. Okay. Okay, doctor. Just type your opinion in the group what you want to discuss, and then I will select some like high yield topic, not like a very minor topic, but like high yield topics for that will benefit for everyone, right? Yeah, ECG, I need to do. Yes, stroke. Okay, ECG stroke and stroke the effect. That is easy part. It easy part that you just need to remember. I will explain quickly. Neurological high. Okay. Okay, I'll do the ECG. Yeah, okay. The thing is, I have to make a small, like a note, right? It's fine. I will do the ECG quick revision. And yeah, yeah, that is all for tomorrow, today, doctor. So we can meet tomorrow. I will mention the time and everything. Okay, so I hope this session helped a lot for you. Okay, doctor. So type your opinion and what you want in the chat, then I can consider in our August group. Okay, then I can consider. Don't be shy, just you can type. Okay, for now I will keep in mind the stroke and the ECG. Okay, then endocrine also. Recording doctor. Let's see. Now I have to go to the bank. After that, within 2 or 3 hours, I'll upload. Okay, because it will take time to convert like around 30 minutes to 1 hour. Okay. Study well. Focus on the high yield topics. Don't study new topics. A special thing is don't study new topics now because you don't have time. You have work hard so much. Okay. Keep that in your mind. Don't be upset if you have not done any topics like a new topics, but just don't chase new topics now because you don't have time. The revision is the key. Okay, revision is the key. And before starting the exam week, make your mind that you have done enough, right? Always tell your mind you have done enough. You have worked hard, right? You have done everything as much as you can, right? You have done so many dedications, you have spent a lot of money on this exam. Keep those things in your mind, okay, and prepare, okay? Don't waste a single minute of your, like this week, because this week is very important. And don't chase new topics, okay? Don't chase new topics, and practice the time management I already shared in the main group. And if someone is having the time management, please, Dr. Tasneem, please share in the August group the PDF and the time management. Then other doctors also can watch. And if you have like if you don't know how to prepare the exam week and everything, there was one video in the YouTube that I have done, like the last minute's preparation. Don't watch the first part of the video. That, like, in the end of the video, I explain about the how exam week, how exam day mentality, and how you should prepare for the exam week, how your mentality should be there. I have explained everything from my experience and other doctors that who have done exam with me. With me mean who I helped, like everything I took experience and all the things. Then I explained everything. Please just like once you are cooking or like doing something else, you can just watch it, because I think that will be very helpful for you to make your mind and everything. Yeah, that's all for now, doctors. Tomorrow I will tell, is there anything new, especially the exam week. You should be very careful. Okay, you should be very careful exam week, because don't remember the answers. Just try to go to the topic. Just try to, if you get a question, just try to go to the key things, keywords, and the key areas that they can ask, because you have the practice now, right? You have the practice. You have done at least 6 months of free calls you have done, right? So you have the practice for those things. And don't use AI for the questions and answers, because don't trust AI. Those answers can be, most of the 95% they are wrong, okay? Especially in the exam week. And if you want to find the answer, always go with the guidelines. Try to find from eMedicine those things, okay? Because I'm telling these things, you have to practice these things now. Then only you will get the, like, you will used to it. Otherwise, you will be very, very panicking during the exam week. You will feel like so lost. Because of that, make sure you have to do these things, okay? Very important. And don't worry, you can do this. Okay, all the best, doctors. Study well. I'll upload after coming from the bank, because I have some bank things to do. Okay, doctors. Thank you so much. And we'll meet tomorrow. I will try to do as much as revisions in this week. Bye bye, doctor. Study well. You can do this. Keep hydrated. Have a good sleep. Yeah, not now, okay, in the night. You can do this. Okay, bye bye, doctors. You got this, okay?